Okay, so Kate Schopmeyer is a physical therapist and program coordinator for patients with complex, persistent pain conditions. Dr. Schopmeyer works with an interdisciplinary clinical team and was integral in creating an accredited intensive outpatient pain rehabilitation program for veterans in San Francisco. Dr. Schopmeyer is actively involved in driving practice changes via national and regional workshops for the VA. In 2013, she became a certified pain educator through the American Society of Pain Educators. She has created and presented many educational modules to facilitate better understanding of pain neurophysiology for patients and clinicians, and has presented at both regional and national pain management conferences. Dr. Schopmeyer's primary goals in her clinical work include fostering active patient engagement, training behaviors that promote self-care, and teaching people to re-engage in life despite persistent pain. She believes that education is therapy and movement is medicine.
Okay, hi everyone. I'm going to be out from behind the podium because I need to move a little bit. And I do a lot of group work, group therapy groups, teaching patients in group settings, movement groups. So I'm used to being in front of people and moving around. So this is hard for me to stand behind something. So I got inspired to give this presentation based on something I witnessed at last year's San Diego Pain Summit, and it was just the tipping point for me. This has been a problem in my clinical work, this use of the 0 to 10 scale to put and then know how to treat them. It's been a problem in my clinical work for a long time. But last year, I'm going to touch a little on this later, it just came to a head from stuff. Are we working now? Okay. So my work is primarily clinical, but I do tend to say yes to many more things than I have time to do. So I sign up for committees and I sign up for projects and I do what I can to try to change behavior of the people around me. I don't think this is working very well. Yeah, thanks. Sorry about the muffles, guys. Okay. Well, if this one bails on me too, I'm just going to have to stand still. Other technical troubles. And it's not even my laptop, so you can't blame me. Well, we learned that the participants of the summit this year were from 7 different countries, maybe 8 including the US. I didn't keep track of the entire count. But we also know that we had a large collection of different types of professionals here. I'm curious if we missed any, and you'd like to just acknowledge what you do professionally? Pilates, movement specialists, excellent. Movement is medicine, right? I mean, I get flack for that phrase with some of my colleagues because the argument is, well, medicine, maybe we should move away from that in general. But I think there's a starting point for everyone who's having to shift their belief system and shift their framework for understanding complex issues. We've heard so much of that in the process that speakers have shared with the audience, their own internal process of making that shift. And I think it's amazing how Rajam has put these topics together. I've sat in the audience and just been flabbergasted at how everything weaves together and the people who have spoken to yesterday, today, and it all lays over top of the others and interlaces and connects. I think it's great. So I hope to make that a little more cohesive in my talk. And I want to introduce myself a little bit more to you all, just to give you a perspective. I've been practicing as a physical therapist since 2005, and I started off in a clinic that taught me primarily how to do craniosacral therapy. That was this thing that my boss wanted to offer his patients in the clinic. So one-on-one time, if you don't know what that is, talk later. You don't need to, I mean, you might want to know, but it's not a focal point of my professional character. But I had an eclectic background in the first 3 years of my clinical work. I did a smattering of things. And I was all excited about all of them. And that perspective has really shifted how I see pain once I got into what I call the tertiary level. It's not my word. I work at the VA hospital in San Francisco, and nationally, tertiary is just one of the levels of care in what's called a stepped care model, which was introduced in 2009. And that's what caused my position to come into existence this summer. All right, I'm switching.
Yeah, I think you guys.
I'm going to have to stand, sorry. So tertiary, where I work, just means I see the hardest of the hardest that went everywhere else first. That's the patient population I have. And these are people who have lost so much because of the pain problem and because of many issues in disability-based systems, which I won't go into today. It becomes a real conflict to learn how to get better despite pain, because there are lots of things that you might lose as a result, and none of this is conscious. But tertiary means we have a lot of different challenges and a lot of embedded beliefs, a lot of long-standing habits of the body and of the mind. And that makes the work particularly difficult, and I'm so glad I work with a team. So I'm lucky. I get psychologists across the hall from me and pharmacists who are talking the same language and anesthesiologists who talk about the nervous system and not just the needle stick. You know, it's wonderful. And I definitely consider myself lucky, but I also recognize there's a huge change we all have to make, which is why I was so excited Rajan decided to include this talk, because this is a great venue to help you all understand some of the framework that might be driving the way we're teaching people to treat pain as a system, at least in the US, and I think worldwide. All the other countries represented here today, you probably have similar stories from your healthcare systems that are driving practices. And I personally think it's very important to try to affect change if you're frustrated by what you're told you have to do. So I'm not very active on social media. I know so many people from social media, but I'm not one of those who spends a lot of time on the conversation threads. And if you look at my posts on Facebook, they happen between 4 and 5 a.m. because that's all the time I have. I do a lot of other things, but in general, what I do when I'm not working is spend as much time outside in the beautiful city where I live as possible. And the weather's much like here, so I get to. And I'm a gluten lover. I might be an anomaly in San Francisco, but I love it. And my husband taught me how to make this bread because he got so deeply upset by losing that connection to his culture when he moved to my country that he had to teach himself how to bake bread like that. So that's what we do at home for fun. I don't have any financial disclosures. The biggest thing I need to say today is I'm not a spokesperson for the VA. I'm a federal employee, but I am not here on their behalf. I'm a physical therapist and a human who works with other humans, trying to help other humans figure out how to get out of the stuck place. So please take what I say as my opinions only and not an official statement from the federal government in the United States. And I want to also make clear that I am arguing in favor of dumping 0 to 10 rating scales or using that as an assessment tool, but only in the context of persisting pain. I think it does have clinical value in some scenarios. And I do geek out on pain stuff, but not so much social media. This looks like a lot. What I really want to do today is provide a historical look to help you understand what some of the factors are that could have led us here in the United States to rely on this method of pain assessment. And if we don't know the history, we're likely to make the same mistakes over and over again. And this is a sordid story, so we'll get to that. I really promise not to bore you with policy and politics. It's not what this is about. It's setting up a historical framework to see how things interrelate that may have led us to where we are, thinking that we have to do things the way they've been done forever, right? I really think that if we don't understand the perspective and the long view, we're likely to stay stuck in the world that we think we have barriers in front of us and we're not going to take action. So I encourage all of you to think about what I'm saying today and take it back to your own home environments and your own clinical situation and figure out where you could push some boundaries and how you could bring some of this knowledge to your colleagues, to your communities. Like Sharna said, this is how we make change and how we transform culture. It doesn't happen any other way. So I really want to tell a story. I want to help you understand how many factors may have contributed. Our original goal as humans in a society was to relieve pain. And unfortunately, so much of what we've tried to do to alleviate pain perhaps has made it more of a problem. There was a great paper, and I wish I had included it. I just thought of it on my way up here, and I think it was published in 2011. Peter O'Sullivan was a co-author on that paper, and it was a striking conclusion where the researchers studied Aboriginals in Australia and concluded that back pain disability was iatrogenic. And if you don't know what that means if they had not gone to see doctors, those people with back pain would have been fine. Iatrogenic. So these are some of the factors that in the United States likely contributed, and they overlap each other. They run in parallel at times. They're big social factors, big social movements, and a lot of concepts and principles that started to play out in really interesting ways. Sharna had spoken yesterday about how we're calling this opioid epidemic, that's the pinnacle of the problem. The problem is opioids, right? And my talk is not about opioids per se, but I agree with Sharna that this is a pain epidemic problem, that we're looking at the pain problem a little bit wrong, which is why perhaps teaching someone to think in terms of biopsychosocial framework might be useful as a starting point. Keith, I see where you're going. I totally get how you got there from the volume of things you've read in 5 years. But everyone comes to a learning process at their own pace. And with adult learning theory, we know we have to repeat and repeat and rinse and repeat and actually meet someone where they're at. So if you're only biomedical, biopsychosocial might be a nice place to take a next step. All right, who knows chemistry? Little bit. Who knows what this molecule is? Anyone want to take a guess? Say it louder. Well, here, I'll help you out. Here's the molecular formula. Does that help you? Dr. Katie, you know what this is? All right. Well, this is the chemical formula for heroin. Why the heck do I care about heroin and its chemical formula when we're talking about numbering rating scales for pain? So this next slide is for Nicolas Ing. You have this German vocabulary fixation. Here you go. Heroisch. Heroisch means heroic, and it is the word used to describe the feeling begotten when people in the Bayer chemical plant took diacetylmorphine. Etiology is fascinating to me. I was a literature major before I went to PT school. So this kind of thing is really interesting, that we've now a descriptor on something that seems like helped people a lot. And by the way, I'm not going to question the ethics of what the people in the line factory were doing, taking the medication they were making. But, you know, that was a long time ago. It was a Victorian era almost. But morphine was distilled from opium for the first time in the early 1800s. And it became very, very popular as an aid to all sorts of ailments and prescribed by lots of doctors. And in the Victorian era, you know, it was given for everything all the time if you didn't feel right, and it helped you feel better, amazingly. But there were lots and lots of side effects, of course, and so people thought, well, the method of delivery must be the problem, so let's invent a syringe and inject it bypassing the GI tract. Unfortunately, not enough was known, and someone died. But that led to a lot of other changes, and if you fast forward 80 years later, now we're really wanting to study this stuff. And we're going to jump around in history a little bit, but this sordid tale of all these factors, including scandalous events and bravery, standing up for patients, having a lot of empathy. There's also greed. We can't deny that. And I'm curious if anyone has been in practice long enough to see and feel a real significant shift in marketing of medication. Yeah? Well, what do we think of when we think of pharmaceutical reps? What's the image you get? Be nice. What's the image? I picture someone dressed kind of like me in a suit, you know, probably heels 4 inches higher than mine, and dragging a little rolly case and going to doctor's offices. That's pretty standard, right? Now we have all kinds of rules, especially where I work, about solicitation of drugs, and that's a good thing. But for a long time, this is how doctors were shown what the medications were, is direct doctor medication solicitation or sales. Now, that didn't exist all that long ago. It was in the 1950s that Arthur Sackler revolutionized drug advertising. And this is a particularity of the United States, and I very much appreciate other countries that don't allow this to happen. I think it's a big problem. But this, Mad Men was a hyped show. Anyone watch Mad Men? Don Draper may have been great friends with Arthur Sackler because this is brilliant marketing moves. And he ended up in a short span of time making a huge sum of money for the company that he started on medications. And I have to say, Dr. Sackler, I'm not really defending him, but I think it's interesting, his personal history. He was a psychiatrist, and he had a real deep motivation to help people, thought it was unfair that the average person did not have access to the knowledge that could have helped them understand that drugs were there that could help symptoms they were dealing with. So he really had a small amount of altruism, I think. I'm judging a man I've never met. But it started in a good place, and that's where a lot of this story starts, is with people who have empathy for other people and really just want to try to make their lives better. And here's a bit of the precursor to the scandal. Now, these people were not the participants in the scandal, but who knows the Porter and Jick paper? Anyone? A few of you. So this paper, this is the paper, by the way. I put the whole thing on here because it's referenced in so many different places, in so many circles in medicine, as a huge awakening and powerful research project. It wasn't. It was someone working in a hospital who thought it was interesting that he had access to data in electronic medical records and collated a lot of that data and published a little tiny letter to the editor, and this is the kind of headline that was born. All right, now that's important. This is really important because we're talking about a time when doctors were trying very hard to help people who hurt. And they were being told to use medications by pharmaceutical representatives that they knew as doctors were dangerous. There was a huge amount of time in the United States where opioids or narcotic drugs were considered off limits until the very end of life. And even in palliative care situations, it wasn't used very often, right? People were scared. And there was a culture of undertreating pain. There was definitely undertreatment of pain in the acute care setting in hospitals. Some researchers in this study found that 73% of hospitalized medical patients had moderate to severe pain. And we know from a number of different research papers across time that unrelieved acute pain can result in chronic pain at a later date. So it's important to treat acute pain and to treat it well. And when you're not worried about scary drugs, that makes the job of a doctor a little easier. So we'll talk about how those things fit together. Another important piece of history here at the same time, a person who was in charge of the cancer program at the time made, and I would love help from audience members on how to say that name because I didn't want to butcher it. Stjansvad? Something like that? I'm going to take that advice later. I can't hear you. But this one also, this man had a lot of bravery because he bucked the norm by saying we should actually create a stepladder for cancer pain ending in opioids so that people can have freedom from pain. Can you see the top of that ladder? Freedom from pain. This as a concept I think is fascinating, using it applied to medicine, because we know now it's probably not possible or realistic, but it sets unrealistic expectations, and that sets the stage for some of the other things that happened later on. Now, around that same time that the Jick and Porter paper was published, Purdue Pharma released a new drug, right? Timed-release morphine painkiller, MS-Contin, stands for morphine sulfate continuous release, and they marketed it as safe and non-addictive. Hurrah, it's safe. Doctors, you can use it. You're not going to harm your patients. Go ahead. It will relieve pain. It will eliminate pain. That's what was being told to doctors everywhere. And there were people recognizing the suffering of patients who were in distress from a lot of pain, and the patients themselves in cancer wards were refusing morphine because they thought it was really bad for them and going to only cause addiction. So Portnoy and Foley published a paper on a small amount of observations they had from patients they were seeing, 38 patients, and they launched this big effort to try and create education programs. So Foley says patients will tell doctors, I don't want to take the drug because it's morphine, and we need to educate patients and doctors. Pain relief can speed healing, and narcotics, if used appropriately, don't lead to addiction. And another thing she says to patients, suffering is not virtuous. So there were a lot of social factors layering on top of these big decisions that were being made in medicine in the 80s and 90s. We're going to fast forward a little. in a slide or two, talk about what went on in the 90s to really shift policy and practice that drove some of how we treat patients and how we assess their pain. So they're running around offices telling doctors, this is safe, go ahead, don't worry about it. And professional conferences were touting the findings of this major study, that tiny paper. The major study, right? We're telling doctors, go ahead and do this. You're not going to make addicts out of your patients. And then patients started to be put in this binary box. It's definitely safe to give patients narcotics, they said. If you have someone who's an addict, that's not a real pain patient, they said. That's just an addict. But of course, it's hard to tell sometimes. So this concept of pseudo-addiction came about, which is really how people describe real pain patients, in air quotes, who are undertreated for their pain. So if you give them enough medication, they will stop behaving badly. That's pseudo-addiction. That's a physical therapist's interpretation of pseudo-addiction. The mental health specialist can correct me. But this is an important shift in thinking, and this really influenced the use of medications and pharmaceuticals to treat pain. And remember that we're all trying to do the same thing. We're all trying to alleviate pain, all of us, however we do it in whatever profession we work. In the 1990s, there was an important speech by the American Pain Society president at the time who argued in favor of using pain as a fifth vital sign. And at the same time, OxyContin was released. It's another drug from Purdue Pharma. It's not morphine anymore, but Oxy. Everyone knows Oxy by this point in time, right? It's got street value now. And in 1999, the VA adopted the fifth vital sign into practice. And I'm going to talk to you a little bit more about that. But what's interesting, too, to me, is that around this same time, state legislations were having to protect doctors who felt really uncomfortable prescribing higher and higher doses. If you don't know anything about the pharmacological nature or the pharmacokinetics of opioids, there's a physiological adaptation that happens, so you need more to have the same effect, and that's not addiction. People call it addiction. It's not. It's tolerance. But doctors were worried about this, and they kept having to escalate the prescriptions to help the pain, and state legislations protected them. That's not the case anymore, which is also sad for many different complex reasons. And the Joint Commissions actually published their first pain management standards, and then we're going to creep in later and talk very briefly about the HCAPs and what that means. And it doesn't directly apply to people from other countries, but you may have similar organizing bodies and accreditation bodies where you live and work. And I think themes might emerge when we consider all of it. Now, overlaying the top of all of this history was this emergence of find it, fix it models in healthcare. And we've heard so many good things at this conference this year, last year, the prior 4 years. And we here, as Keith said, we're the elevated ones. We know better, right? But it's not that simple. Everybody who was working in that era really thought they were doing right by the people they wanted to help. Did you notice a little shout out to Dr. Barmjam down there, vomits? If you don't know his vomit poster, it's an excellent clinical tool. I put his website up there. Victims of medical imaging technology. Iatrogenic, remember that word? You see something on your written letter from your medical imaging report, you'll look it up in Dr. Google, freak out. Now we have a lot of catastrophizing. So this is a kind of social culture going on around that time, right? This Time magazine article, less pain, more gain, yay, we're going to eradicate pain. But doctors who were trained that if you have pain, there's a thing to find and to fix, they're begrudgingly saying, well, I know better how to treat the patient than the patient knows, because I'm the doctor, right? So I think this language is interesting. Doctors have grudgingly come to recognize that the patient is the best judge of how he or she feels. Keith Waldron, thank you very much. Everybody else who said the patient knows, everyone here on stage yesterday and today had made mention of that somehow. And this is another mistake, part of the scandal. Look at that, landmark study. Landmark. The authors of that editorial letter didn't even remember publishing it when they were asked later. And they didn't even think it made any blip. But come to find out, they're surprised at how much of a blip it made, a wave, actually. So hospital reform was big in the United States, and the Joint Commission's been around for a long time, but they didn't start publishing anything on pain management standards until 2001. And we're going to talk about this. This came up in conversation last year. It comes up in conversation with me at work all the time. But aren't we mandated? Don't we have to ask? Who thinks you have to ask 0 to 10 where you work? Nobody thinks that. Is that because I've already told you you don't have to, or is that because you... Has anyone felt pressure or felt annoyance of asking? I know a lot of massage therapists, you are lucky enough to not be beholden to all the documentation rules that we have in other health professions. But you might, here's where I think it's a poignant piece of conversation is, you might be the recipients of complaints from your patients about how they're treated in hospital systems and how they're treated in outpatient care clinics where they just don't want to be asked anymore. Stop asking me, it's not helpful. And I find working in interdisciplinary care that having that broad perspective can help me be a better team member to those other clinicians who are also trying to help. And you could perhaps reframe and help that nervous system calm down when there's this expression of frustration from how they're treated elsewhere. By saying something like, well, you know, I learned a little about this, and I'm not sure it's really necessary. It might just be that the people who treated you don't know that, and they're just trying to help. They might have other rules they think they have to follow, and they haven't actually learned they don't have to. And the truth is, healthcare systems don't disseminate this kind of thing as easily as you might think. So I'm not saying I'm a big fan of the Joint Commission where I work. This is a dirty word a little bit. It's like if you lived in Gotham City, the Joker's coming to town. Nobody likes these surveys. Nobody likes to have all their business looked into deeply. What they do is come and they come to your facility and they look at your medical records. They ask hospital administrators what they do, how they do it, how do they prove that they're doing well, and how do they hold up their end of the agreement to adhere to these standards. And the interesting thing is, with hospital policy, standards are vague. Standards are one thing. These are the examples of the primary standards for pain. They've been updated in 2018, so these don't include all of them. But how a hospital executes this, or how a hospital system with outpatient clinics will execute this or operationalize these standards, is not dictated. Administrators have to come up with that on their own. So they come up with that based on their demographic and their ability to disseminate information and control the environment. And that's not so easy. So in the VA, the Pain as a Fifth Vital Sign toolkit was released. And in general, the way this looked was mandated clinician education and mandating that all nurses performing any intake had to ask, what is your pain rating 0 to 10? They had to ask it and document it, and ask it in any clinical setting. And if you actually dig down in some of the language here, you can see some interesting things. Ask the patient what pain rating would be acceptable or satisfactory to him or to her. This helps set a realistic initial goal. This sounds so clean and tidy, doesn't it? Zero pain might not always be possible. Clean and tidy. But then if you dig deeper, you actually see that the initiative required not only that nurses ask patients every time, every interaction, and document it, but beyond the documentation of pain intensity, that a pain score of 4 or higher would trigger a comprehensive pain assessment and prompt intervention. 4 or higher. This is what the National VA decided to do in order to operationalize the pain standards. So I ask people who live with pain, people who live well with pain, we have a number of them here in the room. Is 4 a number you would say keeps you from doing these things? Is 5? Is 6? Is 7? I think that's impossible to say. I can't say it because I don't live your pain. But this is pretty conflicting, right? The person's supposed to tell us what's acceptable, but if they say higher than 4, well then we have to act. Right? So it creates this element of need for the clinician to do something, this pressure, I have to do something, and limited clinical tools, limited clinical times makes for not such good outcomes. All right. They've gotten a lot of flack for this. Okay? So in 2016, the president at the time actually wrote a rebuttal and published it. We never said to. We never told you to, people. But different hospital systems take this action differently, and they try to operationalize differently. But that doesn't mean it's not changeable, and that's what I'm on a mission to do where I currently work, and it's not easy, even though I'm fired up about it. I don't quite have the level of excitement that Sharna has today, but you see me at work, and that's how people would describe me in my circles. So I relate to that. I appreciate that very much. So jumping over briefly, around the same timeline, 2002, remember 2001 was the Joint Commission Standards on Pain, this thing called HCAHPS, Hospital Consumer Assessment of Healthcare Providers and Systems, which is mandated by the Centers for Medicare and Medicaid Services. Now, all that's mandated is that these scores are taken, these surveys are delivered to patients in hospitals and publicly reported. That's all that's mandated. And the survey is nothing more than 27 questions asking the person what they thought about their hospital stay. In a consumer-based society, that sounds great, except that's not so easy to apply to a major hospital system with a lot of moving parts and a lot of risks to manage and a lot of unintended consequences if you just do what a person would think is best, like, I don't know, have soft music and no noises and all that stuff is important. I agree with that. Pain management is among the domains that's asked. But here's the kicker. Hospitals stand to lose money, not only reputation, but profit if pain is poorly managed by report of the person in pain, right? So if we're requiring that we ask them 0 to 10 and they hate being asked that question, that by itself will result in a poor survey score, right? Not understanding the problem. And evidence suggests that higher levels of pain and depression, this is no-brainer, are linked to poor satisfaction in ambulatory care settings. You all know that, you feel that, right? If people don't feel heard and don't feel cared for, their pain will be higher, very likely, because of a number of factors that have been discussed here this weekend. And it's not simple. Now, you might have been in the hospital recently, you might have a loved one in the hospital, and you might have felt that this dummy got better care than your loved one did. But that doesn't necessarily mean when we're looking at metrics for other health outcomes that bad surveys mean bad care. This is the tricky thing about trying to rely on subjective report surveys to run huge organizations. I am not a huge advocate of just pushing policy. I just want to reflect on the complexity of this problem. So we've covered a couple of these factors, and I'm now going to talk more about that overlay that went on around the same time, the find it, fix it model. And if you squint at this, you'll understand what you're seeing. I'll give you a little help. So what you're looking at is parallel data from years 1994 to 2005 or thereabouts, 1997 and 2004, a number of different data sets. And on the side here, the top left box is measuring the number in thousands, so 300,000 in 1994, the number of MRIs, right? And across from 1994 to 2005, quadrupled. You look at opioid analgesic prescriptions for spine problems, similar trajectory, nice correlation there, right? You look at epidural steroid injections and lumbar fusion rates. Those of you who know Dr. Hanscom, I don't know him personally, but he was practicing in this time. And he would tell you first and foremost that he felt badly if he couldn't offer a surgery to someone to fix their pain. This was the thought process. We can find it, we can fix it. We can help. And these are very good people trying to help, right? But misunderstanding a complex problem. And more vomit. Now, what if you can't see anything? What if, as Joletta's experienced, you're super strong and you still hurt? And what if there never was an injury? A large number of people I work with can't point to a single thing. They can't, but they suffer and they hurt. And when forced, they will give you a number, rating that suffering. And so this, unfortunately, in my opinion, led to a culture of if we can't see it, it must be all in your head. Which is exactly why Maxie needed to reframe, which is exactly why we get frustrated when someone says, out of 10, mine's a 13. Because we've only given patients one tool to communicate as a system, and that's a problem. Maxie yesterday said very nicely, what are they really trying to say? What is your person really trying to tell you when this is the response to how much do you hurt 0 to 10? Wonderful paper in 2015. It's short. I encourage you to look it up and read it. Jane Ballantyne and Mark Sullivan wrote about using intensity of pain as the wrong metric for chronic pain. And this is a beautiful excerpt, I thought. Suffering may be related as much to the meaning of pain as to its intensity. The meaning of pain. We've talked a lot about that this weekend and in past conferences here in San Diego. Persistent helplessness and hopelessness may be the root causes of suffering for patients with chronic pain, yet may be reflected in a report of high pain intensity. So we made a big mess trying to help. We made a big mess, but that doesn't mean we can't improve things. That doesn't mean we can't change directions, change tack. And when I'm working with people who suffer, as Laura Mosley said at the start of the day, it's not a quick journey. It's not a journey that's easy or without challenge or even follows a trajectory you can think about. I'm summarizing in my own words. But what I do know is that just like any big ship out there on the big ocean, if you change your tack a couple of degrees, you're going to end up somewhere completely different. And that's what I hope to do here with you, is to shift your perspective a little bit. There are things we can do on a policy level, on a systems level, even if you don't work in a setting where I work. You can get involved in your local professional organization. You can get involved in your local community. You can push the boundaries. You can question and challenge and stay skeptical and ask your policymakers, really, do we really have to do it this way? Because the answer often is maybe not. I'm excited about next year's conference lineup. We already know some of the speakers. Acceptance and commitment therapy is a tremendous modality or treatment approach. And I do have enough time to do this, I think. Here's a little sample from a physical therapist, right? I'm not a psychologist, but I work really enmeshed with them, and I've learned a lot. Do you have a piece of paper in front of you? See, I work with veterans, and when I say acceptance and commitment therapy, their brain stops at acceptance, and they say, no way, I'm submitting to this shit. I'm not giving up. I'm not giving in, right? That's not what that means. Acceptance and commitment therapy is a little more like this. You have a piece of paper, put it right in front of your nose, maybe touch the tip of your nose. You're touching the tip of your nose here. Open your eyes, describe what you see. You don't have to do it out loud, but just imagine how you describe what you see. Describe everything in your immediate view and what you can see in your peripheral vision. This paper represents your pain. And when your pain is all you can see, it doesn't leave room for much else. All right? But if you hold that paper now very far from yourself, now what can you see? Look around. Pain did not go away. You did not change the size, you changed the perspective. The number doesn't matter as much as what it does to the person. So acceptance and commitment therapy might be one avenue you can explore in your practice, or at least principles you can familiarize yourself with to help change the conversation with your patient about how to engage with the suffering and how to change their viewpoints on what they can do. This is an interesting paper from hand surgeons who took a group of patients post-operatively and did qualitative research to figure out who were the people that did better and why did they do better. What are the resilience factors? Take-home message? Self-efficacy. So when someone has the sense that they can manage themselves and that everything will be all right, now notice it doesn't say that your pain will be zero, but when someone internally feels they can manage themselves, they do better. So that's where you all can come in day to day. And I was inspired by the patient panel last year. In fact, right next to Monday morning, I was, as you may have missed in my first slide on getting to know me, I chair the San Francisco VA Hospital System Pain Committee. And the next morning was our bi-monthly meeting, and I said, you guys, this was so exciting. I went to this conference, and these patients were out there, and it was really important, and we now have to act. I've been talking about this for 2 years, and we have to do something about the 0 to 10 scale. It's driving me nuts. And it's a year later, and I haven't been able to do anything for a number of reasons, but it doesn't mean I haven't tried. And I will tell you, I've set up meetings with ER chiefs and primary care chiefs, ambulatory care service chiefs. We've had sit-downs, and I have a lot of passionate people who want to get involved with me and who are ready. They're chomping at the bit. Tell me when, Kate, we're going to do it. Tell me when, and I will do it. But where I work, we do have these policies that we're beholden to until something changes. It's on the verge. We're going to change it. I'm talking with people at the national level. They know it's a problem. It's not me influencing this. I'm just pushing a little bit. But I think it's exciting. And I wanted to include Mark because he had a nice quote in here that encapsulates some of this in his own words. Instead of asking 0 to 10, given your current pain level of discomfort, how will you be limited today by your pain? That would be a much more helpful question than some random number between 0 and 10. I'm heartened by the fact that many healthcare leaders are recognizing we have a problem in culture in healthcare in the United States. We do have a problem with that. There are people working to change. It is not easy, but I'll give you just a couple slides from now, just one way you can think differently about this and use some of these bigger frameworks that are being rolled out where I work to try to change culture and really get at the root of the problem. But I think what's important, even though this conference by design is really trying to present ideas and to challenge our understanding of things, I also know from a frequent conference attendee that I like to have something I can do. And I'd like to just challenge you to think about what can you do differently tomorrow with your very next client or whenever you see the next patient or client walk into your office. This is what we're doing now. There is a thing called the National Office of Patient-Centered Care and Cultural Transformation. It's a mouthful. The Office of Patient-Centered Care and Cultural Transformation is now rolling out this whole health thinking, whole health wheel. You can't see all that, but you can look at the wheel online right there and print the PDF if you want it. I have this hanging in my office because it's a good reminder. People come to us with different needs. They might not want to see you because of their pain, but if you're asking them about their pain every time, is that going to help the therapeutic relationship? They might be there thinking to themselves, I'm functioning just fine with my pain. Can you help me learn how to walk a little farther without getting tired? I mean, we don't know till we ask. So what matters to the person? Ask, right? What do you want your health for? I mean, these vague ways we ask about measures in healthcare don't get us very far when it comes to the individual. And as so many people have highlighted here and so many people have discussed online with each other, learning how to become interactors and not operators, Diane, I love that. How can I best help you get to that path? And I am reassured by some of the early thoughts I had in the first years as a clinician. I remember saying to patients, if you're still seeing me after 6 times or 8 times or whatever it is, given the problem, and you're not able to do this on your own, I've done something wrong. And I don't know if everybody thinks of it that way. I don't know if that's the right way to think about it, but this is what comes to mind when I think about being servants to patients and not just helpers. So as a next step, what we're trying to use to meet the mandate for asking about 0 to 10 is at least we're rolling it in with something else. Erin Krebs in Minnesota, she's the lead author on this study, and she's done a validation study and lots of other follow-up studies. But you can ask about pain intensity. It might have some clinical value. It might have some personal value to the one in front of you. But how does pain affect you? How does it interfere with your life? How does it keep you from doing what you'd love to be doing? How does it keep you from feeling like you? Those are more important questions. This is a little framework that's easy to roll into a documentation template. And I recently came across this post. If you're not familiar with Nick Hanna on Instagram, that's where I follow his stuff. He has great synthesized, tiny little nice phrases. The bottom 3 questions are his. I put the top one on there because that's what I ask my patients all the time. You might not have any idea, even if you ask the story. And I think it was maybe Tim who said people take time to even get comfortable enough with you to tell the full story. But if you can drill down in your short office visit, everyone here, I think most people in your profession have more than 12 minutes with your patients, and that's great. But a large number of people who do the bulk of the work in clinical care don't have much more than that, which is why doctors cut their patients off after 30 seconds of talking, right? But if you can drill down and ask what concerns you most, it might be, I'm afraid that it's going to kill me. I'm afraid that I have some disease that doctors haven't found. I'm afraid that I'll end up in a wheelchair and I won't be able to walk. Or I'm afraid that I won't be able to throw a ball with my grandson when he comes to visit. It's all over the map. And unless you ask, you don't know, because you might not even need to focus on the pain. I appreciate so much what Barrett Dorco said. I do. And that might not be the patient's primary reason they're there to see you. And if you are in a place where you have to ask or feel like you have to ask, this is maybe another better scale, because if you probably can't see all this. I couldn't make this image any bigger without distorting it. It attaches functional language to all of the things. So since I can't read it either, I'm getting to that age. Number 1, hardly notice pain. Number 2, notice pain, it doesn't interfere with activities. Number 3, sometimes distracts me. Number 4, distracts me, but I can do my usual activities. Number 5, starts to interrupt usual activities. 6, hard to ignore. I'm avoiding my usual activities. 7, focus of attention is on the pain. It prevents me from doing the daily simple stuff, right? 8 is awful, hard to do anything. Can't bear to be in pain at 9, unable to do anything at all. And 10 is I can do nothing but think of this pain. So that might be another way to give a different communication tool to patients if you feel beholden to use a 0 to 10. Maybe most of you don't, and that's fine, but you might work with people who do. You might have social circles and professional circles where people do feel obligated to use this, and you can share more knowledge with them. Education is therapy, and it's power. But if you hate the numbers, this is tongue-in-cheek in the last couple seconds. You can read, boyfriend might, have you read this? Hyperbole and a half, boyfriend doesn't have Ebola, probably. I'm not experiencing any pain at all. I don't know why I'm even here, is 0. I'm experiencing an odd sensation. It could be pain or it could be a mild itch, number 1. Number 2, sorry to bother you. I probably just need a Band-Aid. Number 3, this is distressing. I don't want this to be happening at all. Number 4, my pain is not fucking around. Number 5, why is this happening to me? Number 6, okay, this pain is like super legit now. Number 7, I see Jesus coming for me and I'm scared. Number 8, I'm experiencing a disturbing amount of pain. I might actually be dying, please help. Number 9, I'm definitely dying. Number 10, I'm actively being mauled by a bear. Number 11, blood is going to explode out of my face at any moment. This is too serious for numbers. You might have patients who appreciate this. I would tread carefully, because there's still a very good chance that if we suddenly start to abandon this use of 0 to 10 or asking people about their pain, that might be a form of invalidation, and I don't ever mean to suggest that. But I think there's a better way that we could communicate with people, could ask them and assess and meet some mandates if that's part of your hospital or healthcare system, or your boss decided that this is how we're doing things. And if you want something a little more cultured, you can use this. So, I'll give you a minute. The woman who posted this, I learned later, she and her mom had been frustrated by a medical visit, and they came up with this together just to process that frustrating experience. So a lot of the histological, that's the wrong term, we're not talking about immune systems here. The historical reference points and the timelines I got from Sam Quinones. If you don't know this book, it's really great. If you have any interest in how things develop on a social level and how things interlink, these stories that make headlines now have a past. And this is really well written. He's a journalist. So I'm ready for questions, and I thank you for your attention. Sharna, yeah.
Thank you, Katie, for the lovely presentation. Just something, I'm sitting here and reflecting that, we're talking a lot about pharma and doctors and the prescription. It made me think about India. Mm-hmm. And the farmers in India they have no regulation. So I have family full of doctors. They get trips to the US fully paid for. They have conferences fully paid for. But they don't have an opioid epidemic. Yeah. So it makes me think that it's it's definitely that iceberg lower down more than just the opioid tip. So this was just my comment, and I don't really have a question,
That's
but
fine.
just
It is a
wanted
complex. It's a complex issue. You're absolutely right, and the way we view pain also affects how we treat it. So if we view it as a purely physiologic messaging system, then it makes sense to inject these molecules that bind with receptors that block the message from even going anywhere. It makes sense, right? But that's a flawed model. That's a flawed framework, and it leads to worsening outcomes. And then there's access issue, and then there's suffering issue, and then there's so many layers to this. But it's true, different countries have different problems, different access, and I think it's hard to debate that the ready access of opioids in the United States was a good thing. And in fact, when there was that push to prescribe and keep prescribing, and it's safe and you're not going to be legally prosecuted, doctors, you're going to be fine. It also, that was a practice injected into a system that wasn't ready for it, that didn't have any screening. If you go to the doctor and get a rotator cuff surgery, for example, you have a surgery for something that is fairly routine in our country now. It might be a bad example because the data doesn't really support that so much anymore. But you know what I mean, right? You go to get an orthopedic surgery, and it's standard practice even still to get sent home with 30 pills, or a month's supply, whatever the dosage was prescribed. And people don't get asked questions about risk. They don't get asked questions about family history of risk. They don't get asked any questions about access. Do you have kids at home? Where are you going to store this? Are you going to lock it up? It's just not treated as a dangerous substance. I don't mean to be on a soapbox about opioids, but I'm talking about a cultural perspective issue where we're trying to use it's like a square peg in a round hole. Like we keep trying to find these fixes for a problem that's way over there, and we're focused here. And I'm glad that some enlightenment is coming to some wider circles. Another question? Jody.
Thank you, Katie. That's great. I've been a massage therapist for 30 years, and I've worked in multidisciplinary clinics. My wife is a chronic pain patient that is very responsible but has had many surgeries. We have physiatrists coming into our little rural area, but their end run around this is epidurals.
Yeah.
And because I understand the whole thing, it's a high-ticket item. So how does one talk to someone that's just like, I'm not doing the pain stuff, but I'm making big money shooting up people?
Yeah.
You know?
I'm going to punt part of that.
Sure.
Just because it's outside my scope of practice to talk about the clinical decision around injections or not. But I do very much respect, and I'm looking at Dr. Katie because you've collaborated a lot with, and Sharna too, a lot with Kevin, I can't say his name, Coccaro. I will get that right one of these years. Kevin Coccaro is an anesthesiologist, pain-boarded pain specialist who did all the injections and all of that. And I work with anesthesiologists who aren't, where I work, people don't get paid more or less for more procedures, right? It's a federal system, so they get their salary no matter what. And yet, I feel we have a lot of work to do to educate patients and their expectations around what this thing is going to do for my pain. That's on us, right? The people who aren't injecting as well as the people who are injecting. Because I can talk till I'm blue in the face, and I've sat there. Here's one example that was striking to me. I had a student with me. I work in an interdisciplinary clinic. As I said, we have set up an assessment model in one of our clinics where in one afternoon we see 2 patients in 4 hours. It's a lot of resources for 2 patients, which is amazing that we can do this. So the patients go from one provider to the other for an hour assessment with each provider. Then we sit together as providers and talk about the plan and then bring the patient back and say, what do you think? What would you like? What do you want to have happen? It's wonderful. But you don't understand, I don't think, until you're in that situation, how differently people will act and behave or present their case to different types of clinicians. And this was so poignant for me. I had a student PT who was following the patient around to each visit just to see how all clinicians did things differently. And this was a 32-year-old woman who went there with widespread pain. She had been diagnosed with fibromyalgia, but she sat in the doctor's clinic first, came to my office last, had gone to the psychologist assessment in the middle. And before the patient came to talk to all of us, my student shared an observation. She said, this young woman sat in the doctor's office. The doctor went through her assessment, and the doctor asked all the questions and then asked whether the patient had any questions. And the patient said, yeah, have you read my MRI? I got an MRI because my back's been really hurting. And the doctor, who is well-versed in all this stuff, who is a great clinician and really broad thinker, I know she doesn't use no-CBIC language. I know she does not do that stuff with the patients because I work closely with her, but she said something like, yeah, it just shows a normal amount of arthritis for your age. It's not a big deal at all. Yeah, and the patient said, okay, thank you, doctor, and then went to the psychologist's office and fell apart in a puddle of tears, scared to death about the arthritis that's crumbling in her spine. And none of that was displayed to the physician. The physician came to the team meeting, oh, this is a simple case, and we all went, no, she's a mess now, and we were able to recover that, and then we had the opportunity to have that conversation with the patient, but this stuff happens all the time, and we don't know it. So what I think you can do in your discipline with your minute interactions with these individual patients is perhaps explore what their fears are, what their worries are, what they hope to get out of a pain treatment, and then see where that belief comes from. I mean, we don't have to be psychologists to do that. What is driving that belief? Because maybe there's another way to get there. Yeah. Question over here.
Yes. In the system that I've been working in, as physical therapists, we're asked to rate pain at the beginning and the end of each 45-minute session. So, I, of course, thought that was pretty absurd and began to try to change that policy within the hospital system. Got to the point where I was able to get confirmation from Joint Commission. That is not required because that was their explanation that the hospital gave.
I know, circular reasoning, right?
Took that to the hospital directors of rehab, which then passed it, and they were shocked that that was not Joint Commission. They took that up to the quality control person who said Joint Commission doesn't understand their own rules.
Adults don't like their beliefs to be challenged.
So, any advice? So what I'm looking for quite specifically is there research out there to show dangers of asking that question? I mean, to me, it shows the therapists feel some pressure to do something to get it to change. The patients feel like they're failures if it doesn't change. But I don't have any documentation to support that belief. Yep,
get in touch with me because I put together a case too for my administrators. I made the mistake of launching into an excited little diatribe on this pilot project we're going to get started on after the meeting last year, and I came back to my pain committee and went like, yeah, let's rah, rah. And then I went to a medical executive committee, and I unfortunately did not prepare my talk very well because a major executive leader in response to my effort to say we'd love to just try and use a different form of assessment and in one clinical setting, just one little thing, she said, but it's required. And I said, interesting you say that because the Joint Commission never required that we ask 0 to 10, and she stopped listening to me. And it was a big mess, and it still is a big mess, so I might have to repair that relationship before I can get anywhere further. How you talk about it is important, but because I had to prepare for further arguments, I have collected some things. And there are some papers that do show some of the possible negative impacts. I don't have those here, but what I did include but then took out again because I always have too many slides, is that the VA published this 6 years later. The answer is, we retrospectively reviewed medical records at a single medical center to compare providers' pain management before and after implementing the initiative and performed a subgroup analysis of patients reporting substantial pain, i.e. 4 or more. And the participants were mostly primary care providers in a general medicine outpatient clinic. And I'm going to not bore you with the details, but the quality of pain care was unchanged between visits before and after the pain initiative. And lots of different metrics were used to describe that, and the p-values and the numbers of people included in those. And routinely measuring pain by the fifth vital sign did not increase the quality of pain management. Patients with substantial pain documented by the fifth vital sign often had inadequate pain management. Now, there's a lot to this. This, I think, could serve as a general idea that, hey, healthcare as a system may not improve. And the executives care about numbers and data and performance measurements, right? It doesn't improve performance of the doctors, and there are some other studies that I know about that could highlight the potential detriments of asking this number all the time, or the way that we might act. I mean, this is in psychology journals mostly, and how asking relives this question of how much do I hurt refocuses the brain on things and helps the rumination component, which we know in catastrophizing measures, the pain catastrophizing scale is very predictive of functional outcomes. And I would say what you can do as a physical therapist, any other physical therapist, my buddy Renee, she was with me in that picture in the first slide. We struggle with healthcare insurance providers and reimbursements. We have to show functional improvement, okay? And a lot of people use the pain scale. I've never understood that because it's not functional, it's subjective, right? But you could say, I'm showing functional improvement and I'm tying it to pain by saying the patient goal will be to get dressed 5 days a week without pain interference. It's measurable. Or with 0% or 20% pain interference. Whatever, you can put a number on it. You can actually change how you're writing your functional goals and satisfy the insurance metric requirements, which is really what they want to know. How are you measuring improvement? That's it. And I would argue the 0 to 10 is not good, because if we have big record-keeping systems in the VA, and a nurse I worked with looked at that, and across the board, numbers don't change when people come through the clinic for chronic pain problems. They just don't when you collate all that data. The number stays the same, and you probably have these patients who say, I don't know, it's always an 8 out of 10. I don't know, it's just always, it's always there. It's constant pain, right? The number doesn't help us do a better job of treating people, in my view.
All right, we have one more question online.
In your opinion, to change culture, what do you feel is of greatest value? Working from within established systems, working from outside that system, or some combination or collaboration between both strategies?
Yes, combination and collaboration, which is, again, why I'm excited to be here, because this is an outside the norm kind of venue. And as this gentleman said, I'm sorry, your name was? Jim. I know we've met before. As Jim said, he tried to buck there. He tried to push back, and he was told no. He was told no. The people who wrote the standards don't even know what they wrote, right? That's very immature thinking, and I think. So just putting all your eggs in that basket is not going to cut it. So I'm working with administrators. I'm working with the people on the ground, the frontline clinicians who are excited to make some change. I'm educating patients about it. I'm coming here. You know, these are the ways that we can start to influence and have a ripple effect. And I don't think it ever works to just be in one place, but I also know that you can't have unlimited energy as a clinician. I mean, Keith did a great job of summarizing in a tiny little synopsis of what it takes to just get through a day. We're people too, right, clinicians, and we have huge lives to manage, and there's only so much bandwidth. So, you know, put your energy where you can, but be informed. I think that's the biggest thing, is if you're ill-informed, you're not going to act. You're going to feel like there's no change possible, that this is just how it is because bigwigs say that's how it is. So question that first, get informed, and then figure out what steps you could take to make a small change where you are in your inner circle, and then disseminate from there. It's a good question.
Thank you so much.
Thanks for your attention.
All right, so it is lunchtime. We're going to be giving away raffle prizes at 2:30, and the next lecture will start at 2:45.